this is Alina, and you're listening to Your PharmD Bestie. Welcome back, everyone, to another episode of Your PharmD Bestie. I am your host, Alina, and today we're talking about something that honestly intimidated me a lot at the beginning of residency and also as a student. And that is how to actually work up a patient. Because I feel like this is one of those things that pharmacy school teaches you pieces and bits of, but when you're actually standing on rotation, pre-rounding, trying to figure out like what actually matters to look at in a patient chart or what like you should be looking at and paying attention to what to present and what not to present to your preceptors, it can feel incredibly overwhelming. And I know for me, like personally, one of the hardest transitions going from a student to resident was realizing that nobody necessarily hands you like a perfect formula, right? And like every preceptor might prefer something different, in terms of what you're looking at or how you present a patient. So a lot of it really comes with practice, repeating and learning how to adjust and adapt. So today's episode is going to be really like a practical conversation about how we approach patient workups, what we prioritize, common mistakes that maybe we made early on, and other clinical care tips that we wish maybe we knew sooner. And I'm joined today by William, who is a co-resident of mine. Welcome to the podcast. I'll just have you introduce yourself, including where you're from, maybe what your interests are, um, currently your residency program, and a fun fact.
Oh, okay. Yeah, that sounds good. Thanks, Selena. So hi everyone. My name's Will. I am one of Alina's HSPAL co-residents, currently at PGY1 with her. I did pharmacy school at UC San Diego and came up to Davis for residency. And we're just wrapping up our PGY 1 year in the next couple of months. So in terms of I guess interests. So clinically, so some areas I'm interested in are oncology, internal med, quick care. Um, from a clinical interest perspective, I think from my admin perspective, I'm interested in things like 340B, uh, specialty and patient operations, and just the finance and regulatory stuff that happens in pharmacy. So those are my admin interest areas.
Awesome. Thank you for that introduction. I would say that as an admin specialized resident, Will is very clinically strong. So I feel like he's very perfect to be talking about this topic with. So let's just start with the basics. When people say like work up a patient, what does that actually mean to you?
So, I guess, yeah, that is a big question in terms of, how to work up a patient just because every preceptor has a different, idea or way of how to, but for me, at least, I think, with first thing I look at is, like, chief complaint, why are they here, how long they've been here. Look at the H&P, see the medications they're on, if everything's has an indication and, what like a rationale for the dosing, the why it's still on, especially like antibiotics, why doesn't it have an end time, things like that. So obviously there's, I could go into the little tidbits of what it means to like work up a patient, but I think just from a general overview perspective, those are this is how, like, I approach, a chart when I first look at things.
Mhm. So it's a lot of, like, collecting the relevant clinical information and being able to interpret it, assess it, and then, provide, like, the interventions, or anything that might need to be changed or not changed, for that patient, especially for us, like, in regards to their medications. I think, like, early on, I thought patient workup meant I need to know, like, every single detail about this patient, and so when I was first, presenting my patient, it was, like, way too much detail, and I would freak out about not having memorized every single detail about the patient, but I think residency, quickly taught me that it's really not about memorizing everything. It's about like being able to prioritize and know what matters most clinically for that patient.
Yeah, I agree. I think, obviously, in school you're taught to, every medication and you wanna go way in depth of every medication, but, we're talking about, like, working up a patient in practice, right? Um, we have to, like, look for the big picture things, and, it'll be nice to and then the purpose of residency, right, is, like, we get the exposure to different clinical areas, different types of patients, and each patient, like you said, they have a lot of procedures going on whatever their outpatient follow-ups are. So there's a lot of subjective and objective data that we kinda have to sort through to see, like, what's the
Mhm.
most pertinent and, how, we kinda triage those things. So yeah.
Yeah, I definitely agree with that. So I think that takes us into maybe doing like a walkthrough of what our actual process looks like when we're working up a patient. I know you mentioned you kind of start off with the chief complaint or what the chief concern or reason for admission is. And I feel like we're talking from like a very like inpatient point of view, just so audience members are aware. There is a difference when you're working up like inpatient versus outpatient patients, but we'll focus on like the inpatient side of things. Um, and the reason for like asking why the patient is here, what their chief concern is. I feel like that frames everything else. And then from there, what else do you usually look at to determine maybe like the reason that they're here?
Mhm. Um, so yeah, we start off with the chief complaint. That gives an idea about like why they're here, why they're still here. There's their past medical history, so what type of procedures they've had in the past, what type of chronic diseases they have, what if they have any um external devices in them, things like that. So, just pertinent past medical history in relation to their chief complaint. Like if they're here for, let's say, heart failure, if they have a history of,
Mm,
very robust cardiac history, then that would be the focus of my workup. I also, they would have their secondary, tertiary, so on problems, but, their primary problem would be like their, uh, heart failure that they came in for. So, oh yeah.
mhm. Oh, sorry. No, I was gonna say, like, I think you bring up a really good point that, like, not every condition may matter equally for every admission. So I like that you talk about like focusing on the main concern and like picking at the pertinent information for that. But yeah, I just wanted to like bring that up, but
Oh yeah,
please
all
keep
good.
going.
Yeah, feel free to jump in whenever. Um, so because like right now we're just going the step by step, right, of the
Mhm,
patient workup. I think the next thing to look at would be like their home meds. Uh, so what meds they are on at home and what meds they're on currently in the hospital, and if the doses are correct based on the med rec.
mhm,
Um, yeah, because obviously like if they say if we say, like, they're here for their cardiac issue, um, they're likely to also have, a lot of different other types of, like, diabetes. If they have a psych history, we wanna make sure they're continued on those meds, in the hospital too. So, so it's important to, check the med regs, make sure everything is up to date, looks correct, they're being appropriately treated in the hospital too. Um, I think after that, um the labs, the objective data would be an also important component. So if we go by the heart failure example, let's say they have the acute decompensated heart failure,
mhm,
things I would be looking at, obviously, vital signs, just in general for every patient. Want to make sure their, BP, heart rate, um, oxygen levels, temperature, their afebrile, things like that. They would like those are all things we monitor. Wanna look at their electrolytes, their CBC, um, hemoglobin, hematocrit, just like a quick glance, like no need to, be like, oh, this went down point 0.1 from yesterday. Like basically just making sure nothing sticks out. And
Mhm.
even if something does stick out, like I wouldn't treat it like just based on a number. Um, I think best way to look at it would be sometimes, all these labs, like they're not 100% correct. Sometimes there might be an error. Sometimes like something goes down.
Mhm.
Um, if there's like a huge hemoglobin drop, let's say 10 to 7, um, a lot of times, it's good to get a repeat just to see like if that's actually their new hemoglobin, especially if they don't have any symptoms of like a GI bleed or anything like
Mhm.
that.
Yeah.
Um, yeah, so labs, how to approach looking at labs. Um, so after just looking at all that, then I start checking the notes, see what the medical team and the other care team members have done so far and how their assessment and plans and if I agree with those. Because I mean, I feel like medicine's a gray area in a lot of things. So
Mhm.
there's multiple correct answers to how to treat certain patients. Some providers have their own style, like they want to give everyone a very specific bowel regimen or whatever,
Mhm.
But in order to like focus on big picture things, we want to look at their active problems and list them in the pharmacist handoff. You want to put the primary problem on top so whoever looks at that patient next knows like, oh, I should be focusing on that problem. I'll still be looking at other stuff, but that's the main issue. Um, I think and then I guess another thing another way to think about it is if we're approaching it from an inpatient perspective, like the goal for us is to get the patient stable enough to discharge so that their outpatient providers can continue their chronic disease management.
Management. Mhm.
Yeah, so like our goal while they're inside is to stabilize them and then just make them stable enough to go outpatient and, have continued treatment. So a lot of their chronic diseases, if they're not like actively causing whatever the issue is, their chief complaint that brought them to the hospital, it may not, um, like just thinking about how to put it, it's basically like it should not be the main focus of the workup, if that makes
Yeah.
sense. Like if this is
Yeah.
not something that we can solve in the short term and
Yeah.
impacting their stay.
Yeah, I'm definitely hearing like and this is something that a lot of my preceptors have like emphasized in the past, even like in the outpatient setting, like always organized by like problem based and what is top priority all the way down to like even less priority, meaning maybe they're already stable. But as pharmacists, like we do still try to be comprehensive in our review of the patient. So a lot of times, like depending on your preceptor at the end of the day, but always prioritizing by like the number one issue that is most pressing. Um, and again, like the active problem, and then kind of listing it down from there. So I think like the way I envision organizing the notes, usually, and this is also how I would present is like usually, for example, having this patient came in for an infection, sepsis, that is like number one issue. And then underneath each problem, it's like the assessment, medication related issues, monitoring labs, and then what my plan is for that patient for that specific problem. So I definitely agree with your approach to like that workup like you were mentioning.
Mhm. And then, like you said, every preceptor, every pharmacist has their own unique way of how they look at everything. Like, it's very unlikely, if at all, that you're gonna find someone who matches exactly how you work up a patient, right? Um, and So I think, yeah, I think we, went over the step by step for how to like assess the patient from just a workup perspective. I guess we haven't touched on the most important part, like the medication related adjustments or issues. So, um, like I'm not, or I guess like I'm sure you also have your own style in terms of assessing it. But for me, usually, we look at the medication, look at the dose. The dose will give insight into what indication is being used
Mhm,
for. So, knowing the medication and what indication is a good starting point. Um, Making sure the dosing is appropriate. So, we're checking the hepatic and renal function. Lots of drugs are dosed based off of those kidney and liver organs.
mhm,
Looking at pertinent or the most significant adverse effects. So, like for example, I had a patient when I was on internal med. They were on tacrolimus. They're a kidney transplant patient. Their same creatinine, like typical person is usually like what, like 0.6 to 1.
mhm.
Theirs was like, like 1.5 or something like that. But basically, you know how, like, we kind of talked about, having like, not treating just based on one number, treating based on
Right, on a
trends.
trend. Mhm,
Yeah. Like, in that case, they're on tacrolimus, you look at their baseline, it's like 1.3 to 1.5, so they are in their baseline. The tacrolimus does cause nephrotoxicity. So, over time, as, they're on that drug for years and years, that will, know, eventually, like, keep increasing that serum creatinine over time. So, that would be some of like, as long as the trend doesn't, like, jump up into, like, AKI definition, um, I would not be, like, trying to actively, find a way to decrease that serum creatinine in that moment. I I guess, like, so I guess what I'm trying to say is, if there's, like, side effects that about a drug that you're like, "Oh, there's, like, a 5% incidence of it happening, and it's most likely not gonna happen," then that would not be, like, pertinent information unless
mhm.
they're experiencing it, and then there's literally no other medication they're on that can cause it, then they can maybe be attributed to that. But, and then also, like, safety, but that goes back to the monitoring the bioscience, monitoring
Yeah.
the adjustments.
Yeah, I think definitely, and for like a lot of new learners, this point is very important because I think that it's very helpful for boards as well. But when you're studying for board, like really the book tells you what the most like top 3 most important like clinical things that you should be looking at for a particular drug so that when you see a drug in actual practice, like you should be automatically thinking like, "Oh, I should be checking like QTC for this drug, or I should be checking LFTs for this drug, or I should be checking this and that, bleeding for any like anticoagulation." And so like once you get more comfortable, like those are the things that you automatically like just immediately start looking at as like the monitoring parameters for the drug after you've like thought through, is this the appropriate drug for the indication? Is it appropriately dosed? Next, it's thinking about like, is this still right for the patient? Is the patient able to like tolerate it? So just like you mentioned, being able to recognize the monitoring parameters or lab values that actually matter for that particular drug versus not.
Mhm. Yeah, I agree. Yeah, I feel like, if we're talking from, like, when we were students to versus, like, residents, obviously, starting off as a student, this is, like, your first time seeing what you learn in practice.
Mhm.
So, it's gonna be a learning curve, but after you see hundreds and thousands of charts patients, and you start seeing like the same things, the same disease states over and over again. You build up that's how you build up your, I guess the muscle memory or the clinical muscle memory. That you're gonna like you're like for example, if you look up what if you have to look up whether ceftriaxone is dosed renally or not, um, you might have to look it up first, a few times, as you get used to it. Like I know I did.
Mhm.
But on like the 10th time, like at that point, like you're like, I checked the other 9 times, like I know it is not renally dosed. So,
Yeah, it's definitely like it comes with practice. I think since you like brought up the kind of difference between like being a student and a resident, I think as a student, again, like Will said, you're really like, even at the beginning, I think what was so helpful for me was creating like a checklist of like questions I had to ask myself, right? Like for each drug, what is the indication? What is the dose? Does this have to be renally dose adjusted? And then it was advancing to like overall looking at the patient and all the drugs. Are there like opportunities to de-escalate? Are there um, other monitoring parameters that I have to look at? I think there's like, I'm trying to think like the de-escalation one, and there's like a couple other ones that are like, you should always like look at first for your medications for interventions. Do you know what I'm talking
mm,
about?
oh, do you mean like when you first see a patient, are you saying like what things to think of first, or?
Yeah, like I guess the most common like interventions that can like easily be made. Those are like the ones that as a student I was taught like, okay, if
Oh,
all else fails, like
yeah.
these are like the
Oh, I
things
see
to
what you
like
mean. Like
think
like renal
about.
adjustments, hepatic renal adjustments. Those are like the pharmacist things, right? Those are like
Yeah.
the interventions like Pepsid, dose reduce if granule function is not good.
Mhm.
Uh,
Oh, and also like if there's opportunity to de-escalate from like IV to PO
mhm.
or like to de-escalate a patient off of an antibiotic, like those are like the top
Yes.
like
Mhm.
3, 4 interventions to like look at. But then as a resident, we have to start, I think like the biggest difference was like starting to anticipate what the next steps were after that. And I feel like that step's very difficult unless your preceptor, like knows how to properly guide you to like critically think and
Mhm.
be able to like get to that point. But I remember as like a student, it was like, okay, like I figured out that this patient should be on this anticoagulant for like VT prophylaxis, and I chose an anticoagulant. But then the next step beyond that, which is more like resident level thinking, is like also addressing barriers to like discharge. And that could include like insurance costs or copays. So there's so much to like think about when you're working up a patient and when you're coming up with a plan. Those are just a couple of things that I like wanted to discuss as well in terms of that difference between being a student and a resident. From your experience, are there certain experiences or like things that have occurred where you like noticed a significant difference in like expectations as a student versus a resident?
Yeah, I think you bring up a good point in the difference between an app or between when you're on your appies versus being a resident. I think as a student, I mean, uh, you're not able to like verify yet, so that is both a pro and con, but it is a learning experience. So I feel so as a student, you're more focused on learning the nuances of like specific drugs, specific disease states. And then, like you'll be able to talk with a resident you're working with or your preceptor about like, your assessment plan, and if there's any considerations that you may have missed, like they'll teach it to you or guide you to that. I
Mhm.
think when you're a resident and you get and after you get licensed, there's some more responsibility. Obviously, like, you would still talk over, like, your assessment plan with your preceptor, but there's the expectation is, like, there's since you are a licensed pharmacist, like, you will be expected to be more
Mhm.
autonomous in how you operate. Like, certain things like, for example, if it's a let's say we're halfway through the year, if there's, like, certain renal adjustments that have to be made, like, dose reducing a Pepsid by 50% or something, those are things like, um, after, you work with your preceptor for a week and, you know, they're I'm assuming, like, they trust you by that point. Those are some things that you would do by yourself and let your preceptor know when you present the patient rather than, as a student, you're like, "Oh, can we reduce or can we dose adjust it?" So it's
Mhm.
just you're expected to be more autonomous, expected to take on more patients since, the real patient care, and, um, basically be the pharmacist, but obviously if you have questions, you can ask your preceptor. So
Yeah,
mhm,
that's a really good point. Is that I think a lot of students and even residents, especially residents, I think feel the pressure to appear like confident and that like they know what they're doing. But I think as preceptors, we still expect or they still expect the residents to be asking like questions, and that's just part of the learning process. So I really like that point that you bring up.
mhm, and sometimes it's like, with your assessment plan, they wanna hear the rationale. They're like, "Oh,
Hmm.
why do you want to reduce it by half?" Or, "We should reduce it by half, but are there any patient-specific factors where we shouldn't?" Um, so I think, like you said, like, there's a different way of thinking that comes with, being a resident, like, we have to anticipate things. I think, my cardiology preceptor, uh had mentioned like, "Oh, like, it's good to have, like, a backup recommendation in case, like, your first one, doesn't get taken." Like, for example, if, let's say, patient was hypotensive, you recommend to hold the lisinopril 20 milligrams. If the team is like, for some reason, they're like, "Nah, like, we wanna keep it, like, we think, like, this will not be an issue for the next dose," or whatever, um, I like, the backup recommendation would be like, "Oh, can we cut the dose in half, like 20 to 10?" Rather so, obviously, we didn't get the best case scenario, like, we were not able to put on hold, but if we asked, like, "Can we do, like, 5 or 10 milligrams?" And
Hmm.
it might be like, "Oh, that is something that we can do." Like, if patient's able to tolerate, we can always increase it back up, and that way you're also mitigating the chance that, oh, like, the hypertensive gets worse if they kept it on the same dose. So, I guess, like, those would be, like, kinda anticipation things that, you mentioned, like, we're not just having only one recommendation, we're
Hmm.
thinking on the spot potentially and having to have backup recommendations.
Yeah, I definitely agree. And I think there's also a component to that in which, as a resident, you become more comfortable and you're able to learn and adapt to working with different people. And so at one point in your like rotation, um, depending on like how often maybe an attending switches out, but you do get a feel of like, okay, with this attending or like this medical team, do I have to give a lot of like clinical reasoning to back up my recommendations, or is this a team where I have to drop just like drop the hint, dip your foot in, um plant the idea, and then have to like keep bringing it up subsequently so that they are more open to the idea. So I think that also definitely comes with practice, but as a resident, um, you do build your skills and your comfortability enough to the point where you're able to navigate that cross collaborative um, relationship as well.
Mhm. Yeah, and I feel like it depends on who you're working with, like you said. Like, if you're working with only the hospitalists, like, fully trained attending versus if it's a teaching team, you have, you know, new medical residents, their senior, and then the attending. Like, the attending will, like, know the rationale, like, they are the attending, but the medical residents, like, for their learning and for yours too, like, it'll be good to, cite studies, cite evidence. Like, for example, if we're talking about, like, going back to the heart failure example, sometimes you'll see, like, things like Farxiga 5 milligrams for, heart failure, and, you know, there some I guess, like, some providers have said, like, they were like, "Oh, they can't tolerate 10 milligrams, they've been getting some side effects, so I'm giving them 5 milligrams so they can tolerate it and still get some of the benefit," which, in theory, it you know, just from, like, a how like, just straight lines, I mean, that makes sense from where they're coming from. However, like, there is no literature backing up the 5 milligram
Mhm,
dose. Like, we don't know if there's, efficacy and mortality, morbidity benefit in, like, Farxiga 5 milligrams. Like, it's only been studied with 10 milligrams.
mhm,
So so you kinda have to explain to the team, um, like, why, like, it's either 5 milligrams, or sorry, it's either, like, 10 milligrams or nothing, essentially. Like, if they can't tolerate it, then we have to DC it. Uh, we can't, like, do this, like, half-baked, like, no evidence dose, if that makes sense.
yeah, yeah, no, that does. I just like how you said half-baked.
Yeah. Mhm,
Uh, okay. Yeah, so I definitely think we brought up, like, a couple of really good points. Now, um, knowing that, are there things that you've done to help you improve your patient workups since being a student? I previously, like, mentioned using, like, temperature checklists because those, like, really helped me. It will slow you down a little bit at first, I think, just having to spend a lot of time, like, looking at everything and making sure everything's checked off, but I think it really helps you build that clinical confidence. But for you, like, what is something that helped you? And this could be for, like, patient workups or even, like, presenting, recommendations to preceptors.
mhm. Yeah, I think, obviously, I think the where we're taught in school is, the most comprehensive way. It's a starting point, right? But, as you transition from APPEs to being a resident, like, we're taught to there's, like, the SOAP note, right? Subjective, objective, assessment, plan. So for the objective, we start off by writing, like, every single, like, lab, essentially. Like, let's say a heart, like, BP, like, you write down 140 over, like, 90, or something like that, right? And then so
Mhm,
when you start off in residency, like, you're doing your workups, you're typing in all these numbers, but, um, like, what's important is, like, if the BP is elevated, like, you can just type in BP elevated, whoever's, like, checking, or whoever's the next pharmacist, like, they will also be looking at the labs, like, if you just mention BP as elevated, they'll know that you assessed it, and then they'll take a look
mhm,
themselves. Like, basically finding ways to cut down on, like, the menial work, if that makes sense.
mhm,
Um, so in your workups, I just plain BP elevated, don't put, like, the whole range. If there's and then, for vitals, if only one vital is not within normal limits, just put down, like, let's say, patient on 2 liters, nasal cannula, and then they will know that there's an issue going on with their O2 sat. You can put, like, vitals, all other vitals are normal limits. Like, in that case, it'll also be helpful if you say, like, what their baseline oxygen needs are. Like
mhm,
like, if they've been living on 2 liters nasal cannula, then, like, that's not pertinent, essentially. Like, this is their baseline. But if it was, like,
mhm,
room air, then, yeah, then 2 liters nasal cannula means they're not stable yet. Um, so essentially just, like, coming down with ways to convey the same information, but keeping the amount of, typing to as less time as possible. So just being more or coming up with ways to make it more efficient, but also leaving like all the pertinent information in the handoff for the next pharmacist.
Mm, I see. Do you feel like that kind of came from feedback that you received from preceptors in the past? Just like modeling it after what others have done?
Yeah, I think I forgot which rotation exactly was on, but I was asking like, oh, like what's the typical workup time you take per patient? And then the preceptors there, they have plenty of experience, like, they're like, new patient, 10 to 15 minutes. Uh, if it's a patient they've been following, like 3 minutes, like, 3 minutes if there's like no issue going on, like it's just like a day-to-day type of thing. And then I'm like, "Oh, okay, that sounds pretty fast." I'm like, takes like beginning of residence, I was like, no, it takes me like, you know, 25 minutes to do like a new patient, right?" Um, and then I was like, "Okay, like, do you have any tips on like what you do?" And then they were like, "Oh, like, like we mentioned earlier, like if it's like within normal limits, you don't have to put the exact
Mm,
lab value. Like you can also say electrolytes within normal limits. No need to put like K 4.3 or or something like that." Um, and then like you said, while presenting, so all the stuff like I'm saying right now is how I present too. Like I'm gonna be like, vitals are stable or like they're febrile, but all their vitals are stable. Um, so I list like the pertinent problem and then active problem and then what relevant labs or subjective, objective stuff is related to that. Like, trying to think of an example. Like, let's say, someone is, in, uh, I guess. Oh yeah, let's just go back to that heart failure example, just since like we've been talking about it. Um, So you're gonna want to know their volume status, you're gonna want to know, their ins and outs, their vitals, like, especially, like, their BP, their, O2 sat, if they have any subjective symptoms, like, in the nursing notes, like shortness of breath, can't breathe, things like
mhm.
that. Um, uh, I guess, I'm just trying to think of, like, something that's, like, a routine lab that is, like, not relevant at all to heart failure, but let's say you have this, like, random, I don't know, like, random creatine kinase that was ordered for some reason, um,
Mhm,
like, no meds for rhabdo and no muscle, it was just, like, ordered, and then it just appears like normal limits on the lab. Like, there's no need to mention that, like, within normal limits, CK, if they're not on any meds and they don't have any, like, issues that can increase the chance of,
mhm.
uh, rhabdo. So, um, yeah, I think
Sounds like, yeah, mainly like focusing on the monitoring parameters or
uh,
labs that are relevant for the medication. Um, and as you guys can like hear, we've been saying this repeatedly because that is such a big part of the patient workup and also with medications. As like pharmacists, we want to always prioritize one, like, is the medication working? But two, is it safe for the patient? And so the only way to really assess that is by looking at these lab values, monitoring parameters, and adverse effects.
mhm.
Thanks for sharing. I think the last portion of of this episode I wanted to go over is just like really rapid fire other clinical tips that maybe we wish we knew earlier. So one of the first questions I had was like, how do you stay organized on busy rotations?
Yeah, I think, every rotation is, gonna be the 8 hours, and you're gonna have topic discussions that you'll work on afterwards and, all those projects, longitudinal projects like research, everything like that going on. For us, we have our MBA classes too. Um, for me, I work out of my Outlook calendar. I So all my meetings, all my stuff I put on there just so if I'm like, hey, like someone's like, hey, do I hang out like 6 p.m. after rotation today? I'll look at it, but I can't have like MBA class or oh, I'm free, you know? So like being organized on a calendar, putting all your stuff, helps you stay organized. I also have a separate list, like a daily to-do list. So I have that categorized in tiers. Like tier one is like must do. I need to finish this today,
Mhm,
like whatever thing I have. Tier two would be like, okay, like this thing is like coming up due end of the week, but it's not due today. But it's something if I have extra time today, I should work on. If I can knock it out, great. And then tier 3 is, like, the back burner. It's like, "Okay, like, I need to finish this, but, I have a few weeks, like, I'll get to it once I finish all the urgent stuff first." So, I have this daily triage to-do list with my calendar, so that's how I stay organized on top of, whatever rotation I'm on.
okay, I see. Yeah, I really like that. I also have, like, a running list of, everything that I have to do that's also prioritized based off of, like, what's most urgent. How would you say you stay organized on rotation? So, like, let's say, for example, you're, like, rounding and then you get a question from the team. You also have a question from, like, a technician, or you have a question from your preceptor about another patient, or you have to, like, but then you also remember that you have to, like, do discharge counseling for a separate patient. Like, how do you stay organized and make sure that you don't forget something? It's definitely happened to me before.
Mm. Yeah, I mean, the examples you provide, I mean, those will happen, right? Like, that's sounds like a typical day, on, like, internal med. Um Yeah, so I think, uh, well, in this case, like the best way to do it would be based off of urgency. Um, so like the discharge counseling, like you mentioned, like when is the patient discharging? Are they discharging today? Like when, like what time? If it's like not now, if it's like later in the afternoon, then okay, like yeah, you have time. If the
Mhm,
medical team, if they have a urgent question about like the, you know, like they're like, oh, we just got a call, a patient has a PE. We wanna start this heparin drip, like, I need help with the dosing, then, like, that takes priority over, like, discharge counseling when the patient's gonna be here for another 4 hours. Um, and in terms of how to triage, like, like you said, you get multiple messages from your preceptors, from your, um, what's it called, other team members. If,
mhm,
like, let's say you're working on that heparin drip, and the preceptor just has, like, "Oh, I wanna know your rationale for, like, this thing that you did earlier, you can let them know like, "Hey, like, I'm working on a heparin drip for this, this is what I want to do. FYI that I will get back to you, but, like, after I finish the heparin drip." So that way they're like, "Oh, okay, like, I know they're working on it,
mhm,
they will get to me after." And also letting the non-urgent questions that the other team members are asking be like, "Okay, like, I'll get to you next after I finish, like, helping with the heparin drip." So
mhm,
essentially, like, communicating with everyone, I feel like that's the easy way, right? 10 seconds, a message, you just send them, "Hey, like, I'll help you after I finish the current thing I'm working on, or I'll get back to you, like, ASAP," essentially. So that way they're not, like, left hanging, and then they know, like, oh, like, you have something urgent that you need to finish. So just, like, the communication first so
mhm.
that all parties know, and then that way you can also take a step back and, think for a few seconds about how to best, address each thing that comes up.
Yeah, I really like that. I would say, like, as a new resident, or, like, student on rotations, like, utilize the systems you have and, like, the resources, right? Like, tools. If you need to create a checklist, and, like, write everything down that comes up, like, please do that just so you don't forget. But the thing next best thing I or next best most important thing I think is the communication aspect, and just making sure that everyone is on the same page. A lot of times, like, even, as a resident, yes, like, I think I'm better at, being proactive and, like, letting my preceptor know, like, initiating, like, "Hey, like, I just got off rounds and I'm working on addressing this question from the team. I will get to like the note later, or like I will get back to your question later. Like I'm currently on rounds. I think that really helps to triage, and it gives you, like Will said, like it gives you that space and time to address what you need to, and then move on to like the next item on your list. And that really helps to help you stay organized, and it can also help you create some buffer, especially when you're feeling overwhelmed or behind. I think also as a student and resident, being honest with your preceptor too about how you're feeling or like how you're handling the task is important, just so they know how to um, tailor the rotation, or how they can find different ways to help you get better or get to where you need to be. And that will overall, in the long run, also help you build that clinical confidence and efficiency as well.
Yeah, I agree. Like, if you happen to be overwhelmed, like definitely let your preceptor know. So, that way, they'll be able to help, step in, help give you some guidance on some tips to, potentially triage different issues, how they would approach different issues. And, you can take bits and pieces that you like from their approach to be your approach. Um, and then sometimes like, if you actually have like a lot of stuff going on, let's say you have a heparin drip and then you have this like warfarin rec and a Vanco dose that you need to adjust and like, just everything. Um, and then like, hey, like I can't finish this within 30 minutes. It's okay to, like you said, like tell the preceptor, okay, I have these three things going on. Um, like I would then the heparin drip's the most urgent. Can you help me with this? Can you help me look at the Vanco dosing? Like I'll, come up with my assessment plan to tell you. But then are you able to like help me in this like next 30 minutes so we can give the dose on time and
Hmm.
patient care isn't affected, right? So that way they're like, okay, like, obviously like we're prioritizing the patient care, but also you're, still saying that, I'm gonna do the work and I'm gonna get back to you on like what my plan was going to be. But so like you said, just the communication, letting your preceptor know, anything that you're overwhelmed with so it doesn't, affect patient continuity of care.
Hmm. Yeah, definitely. Well, I think that takes us to the end of the episode. So just to close it off, I think one of the biggest takeaways from today's episode for me was really being able to solidify that working up a patient is a skill that you learn and develop over time. It's not something that you're just innately born with, that talent to. Nobody starts residency or really like
Yeah.
school knowing exactly how to clinically think through every patient case. And really, like, you have to develop those skills through repetition, feedback, observing others, and just with experience. And then relying on systems to help you keep improving as well.
Yeah.
So, mhm,
I yeah, I was gonna say I agree with everything Alina said. I just wanted to add that obviously, know, uh this is something like working with a patient, like this is something that takes time to build up to. Um and so like if you're just starting off on residency, like and you have like 40 patients on rotations, like I know there's a pressure to take on all 40 patients or something like that, but it's okay to start with, with like 10 and then slowly build your way up to like, wherever you are at. If it's your first rotation, something if you can only hit like 20 patients out of 40, and that's like your limit for quality without or quantity without sacrificing quality, that's okay because you still have the next 10 months to build up to that staff pharmacist workload. Um, but yeah, just want to I guess highlight what Alina said about like it's a skill that takes time to develop. Like you will not like it. no one's gonna like show up out of nowhere and like know how to do all this.
Yeah, yeah, I think you bring up, like, a really good point, and I'm very thankful that you bring that up because, um, I think the 2 of us, correct me if I'm wrong, I think we both ha are more, like, internally, I think we do have, like, high expectations for ourselves on rotations. I know I do at least. And like even if it's like a completely new rotation, something I've never learned before, like I internally like expect myself to be able to understand everything and do everything on my own by like the end of the first week. But that's just not like the reality of things. And so even as a resident who was about to finish my first year of residency, like, I'm still struggling and, like, learning to be gentle with myself and, like, understand my limits, and so, just wanna piggyback off of what Will said, like, this is definitely, like, a takes a lot of time to work up to that point.
Mhm. And
So
then
mhm,
I think, oh, and then just like one other thing I think we should mention, like it's okay to like not know stuff. Like a lot of times, if I like don't know, like I do not guess. Like I will straight up say like I don't know. I'm gonna look it up, or this is what I know about this situation, but I don't know for sure, so I'm gonna double check. So like the preceptors will no, they want you to do that. Like they do not want you like guessing like what you would do because that could be a danger to patient care. So it's okay to say like hey, I don't know, but I'll look it up, or this is what I would do if I didn't know.
yeah, I think there's definitely a balance between, being, like, confident and also being, like, humble enough to admit that, like, "Hey, this is not something I know. I'm still a learner, but I can learn. I can look this up, and I can get back to you." So, I appreciate you bringing that up. Well, thank you again so much for coming onto the podcast and having this conversation with me. I do think that listeners are going to find this episode helpful or at least reassuring, especially for students or new residents who may feel overwhelmed as they go through APPEs or rotations. And honestly, it's been really nice reflecting on the growth that's happened this year as well. So to everyone listening, thank you so much for tuning in to your PharmD Bestie. If you enjoyed today's episode, make sure to subscribe, leave a review, share this episode with someone who may be starting residency soon, and let me know in the comments or DM if you have any other questions. I will address those. Will, do you have any last words you'd like to say?
Um, yeah, I mean, yeah, thanks for having me, Alina. Subscribe to your podcast. Leave a review or any comments. We'll love to hear what you thought about our discussion.
Thanks, Will. And as always, I'll talk to you guys in the next episode. All right. Bye, y'all.